About diabetes and kidney transplantation, which is very important topic. First of all, I would like to thank Professor Mujahid Abulmagd who invited me to chair for the second consecutive year in this valuable meeting of Delta Diabetes Association. The outline of my presentation today, I speak some slides about why diabetes is important when we think of transplantation. What are the transplant options available for diabetic patients? Regarding post-transplant diabetes, what is the best definition? What are risk factors and the outcome of post-transplant diabetes and the management? Regarding donation diabetes, can we accept diabetic person to donate? What are the impact of donation on the occurrence of diabetes or impaired glucose tolerance? And what's new? This will be at the end of my presentation. So regarding why diabetes is very important, when we think of management and replacement of end-stage kidney disease, because diabetes is the leader in the major cause of end-stage kidney disease. As you see, if we speak about the number of patients in thousands or prevalence per million, diabetes is the first and the most important cause for end-stage kidney disease. And when we think of renal transplantation, we should evaluate the patient thoroughly, especially for the cardiovascular system. So standard exercise tolerance test should be done, and then non-invasive. And if there is any coronary event, coronary heart disease, the patient should be subjected to coronary angiography as a preparation for transplantation, and then to proceed. And diabetic nephropathy is a recurring disease, although it is recurring but doesn't cause graft failure. So we should differentiate between recurrence and graft failure. If we look at the quality of life, if we compare diabetics versus non-diabetic, we'll find here all domains of quality of life are lower in diabetic in comparison to non-diabetic, including speech, hearing, ambulation, vision, pain and discomfort, cognition, emotion, and dexterity. Another important point is fracture risk after renal transplantation. These patients are fragile. So there is a lot of risk factors leading to bone fragility and the risk of fall and the post-fragility of the bones, and the risk of fall lead to fracture. So what are the risk factors for bone fragility? Type 1 diabetes is associated with increased advanced glycation in the products, insulin deficiency, low body weight. And when CKD or end-stage renal disease develop, it is associated with renal dystrophy, vitamin D deficiency, and decreased weight-bearing activity. After transplantation, the patients are treated with glucocorticoids, hypophosphatemia, and post-operative immobilization. All these are risk factors for bone fragility that may lead to fracture. Regarding the risk of fall, we have neuropathy, hypoglycemia, amputation for the diabetes, and myopathy after chronic kidney disease and malnutrition, and during transplantation, steroids and other factors. So the patients with type 1 diabetes is associated with increasing risk of fracture. Again, this is the survival after transplantation. If you look according to the primary disease or original kidney disease, diabetic patients have lower survival in comparison to other etiologies. But currently, we shouldn't deprive diabetic patient from transplantation because there is an improvement in the service with the consequent improvement of the patient survival. If you look here, patient survival after 5 years, black bar refer to diabetics. Here the survival is lower in diabetic, but here the survival improves with time to the extent it there is marginal difference between diabetic and non-diabetic. And one of the reasons of improvement is the multidisciplinary team approach. Pharmacists manage diabetes and the cardiovascular risk reduction clinic in kidney transplant recipients. This may bridge the gap in care transition. What are the options for transplantation to a patient with indecision disease diabetic, we have live donor kidney transplantation, and this is the best option whenever the patient is evaluated. Whenever if the patient suffers from type 1 diabetes, the best, if available, the combined simultaneous pancreas and kidney. Why pancreas is important here? Because pancreas, if combined with kidney, decrease the risk of recurrence and improve glycemic control and to avoid insulin as possible. Combined pancreas and kidney is superior to pancreas after kidney, because combined pancreas and kidney we take the organ from one donor and the comorbidity is less. Okay, this is the cartoon for combined pancreas and kidney. If you look here, this is the enteric drainage of the exocrine function of the pancreas and the portal vein, venous drainage to the portal vein, and this is the more physiological to simulating the nature. Here, this is the venous drainage to the systemic circulation, and the exocrine function is drained to the bladder. So this is two methods of combined kidney and pancreas. If we combine kidney and pancreas in type 1, this is the best patient survival and the best graft survival for the pancreas and for kidney in comparison with type 2 diabetes kidney transplant alone. But we shouldn't deprive these patients from live donor transplantation, because live donor kidney transplantation for these patients have the best survival. In type 2 diabetes, as you see, the percent of combined pancreas and kidney is just 7.4%, and pancreas after kidney 4.1%. And the majority of patients type 2 diabetes are transplanted kidney. So regarding fracture, if you compare the patient who are non-diabetic and receive the kidney, the incidence of fracture per 1,000 patients per year is 7.2. If type 1 diabetes, pancreas and kidney is 12%. If kidney transplant alone, it's 15.8%. This means that if we transplant kidney alone, fractures increases. So, and these are the distribution of fracture in different bones. As you see, the white color bar reflects simultaneous pancreas and kidney, and the black one reflects kidney transplant alone. You find here the majority of sites the fracture is less in simultaneous pancreas and kidney. Why? We don't know. Does pancreas have endocrine function affecting the bone? We don't know. This slide summarizes the 1 year, 5 year, and 10 year survival of combined pancreas and kidney. This color refers to the all-cause graft failure, death sensor graft failure, and death with function graft. You can look at the numerical values. Here there is marked improvement through the years. This is as you see, this is the total. The all-cause of graft failure decreases by time. And this is the pancreas after kidney. Regarding second sector, which is post-transplant diabetes diagnosis, is it no onset diabetes after transplantation, as we read in many literature, or it is post-transplant diabetes, which is correct? The most appropriate is post-transplant diabetes. Why? Sometimes we don't know if the patient is diabetic or not, and sometimes if we apply oral glucose tolerance, we can diagnose a non-diabetic, as this study shows. So the proceeding from this international consensus that was recently published last year, the recommendations include changing terminology from new onset diabetes after transplantation back to post-transplant diabetes mellitus. So this is the most accurate definition. And this is a very important slide, because not all hyperglycemia that you may encounter or diagnose after transplantation is diabetes. Here, if the hyperglycemia occurs within the first 6 weeks after transplantation, we shouldn't say post-transplant diabetes, except if it persists after this period. So if you find hyperglycemia in this time frame, you can say post-transplant hyperglycemia transient. and if it persists beyond this period, it is post-transplant diabetes. Here you can find diagnostic facilities. Usually we use oral glucose tolerance, fasting random glucose, and lastly A1C, because A1C is not accurate in the domain of transplantation. The same here, oral glucose tolerance, A1C, and fast and random, and this is the treatment modality. If you diagnose hyperglycemia immediately after transplantation, insulin is preferred, especially the intermediate insulin, because it saves the islets of the pancreas. And then if it is late, we can use the same line of management of type 2 diabetes, lifestyle modification, oral antidiabetic, and then insulin. Regarding epidemiology, this is one of the studies that showed the epidemiology. This is 570 transplant cases. 59% of the patients showed normal glycemia, impaired fasting glucose in 12%, impaired glucose tolerance in 7%, impaired fasting and impaired glucose in 8-9%, and post-transplant diabetes in 12.5% of the cases. And this is the same. You can find here 30% of the patient after this time of period of follow-up suffers from post-transplant diabetes. So it ranges from even less than 5% to 50% of the cases. And post-transplant diabetes adversely affect the outcome of the patient associated with higher risk of cardiovascular, and it affects the survival, graft survival. So it has consequences: lower graft survival and function, lower patient survival, and increasing risk of cardiovascular disease. What are the risk factors for post-transplant diabetes? Body mass index. So we should respect obesity before at the time of transplantation. The higher the body mass index, the higher the risk of post-transplant diabetes. Not only the body mass index, but visceral fat that can be evaluated by DEXA scan. Even it is more accurate and more predictive of post-transplant diabetes than obesity. Another factors, as documented by oral glucose tolerance, the age. All these factors are the time of before transplantation, the older the recipient age, and the presence of pre-transplant impaired glucose tolerance, the higher the body mass index. And this is very important and interesting. If the etiology of the renal failure is related to autosomal dominant polycystic kidney disease. Why? We don't know exactly. A lot of publications showed the link between polycystic and diabetes, and this may be due to the presence of cyst in pancreas or to other factors. The higher the number of risk factors, the more the risk of diabetes. Regarding the immune suppressive medicines that are used after within transplantation, after transplantation, if you look, the calcineurin inhibitors, cyclosporin and tacrolimus, steroids, mTOR inhibitors, all of these drugs are diabetogenic, either increasing insulin resistance or decreasing the beta cell production of insulin. So it may have direct toxicity on islets or increase insulin resistance. The anti-metabolites, adenosine and methylphenolate, are not diabetogenic. This is one of the mechanistic approach. Here the calcineurin is important for building up of this type of muscle fibers that are very important to improve the insulin sensitivity. So calcineurin inhibitor, including cyclosporin, tacrolimus, block this action, leads to increasing insulin resistance. This is the cartoon showing here the insulin resistance and insulin secretions are the major mechanistic approach toward the post-transplant diabetes. Steroid and sirolimus affect both increase insulin resistance and decrease insulin secretion. Cyclosporin and FK affects mainly the islets through islet toxicity. This study showed that sirolimus-based regimen is more diabetogenic than other regimen we have. This is one of studies that was published from Mansoura Regional Referral Center. The complication after steroid-free, the patients were treated with tacrolimus and methylphenolic acid, in comparison to steroid maintenance with tacrolimus and methylphenolic acid, post-transplant diabetes decreases significantly if we withdraw steroids. So this is 5% instead of 15%. So this is the steroid is important for the causation and for increasing the risk of post-transplant diabetes. If the patient suffer from frequent episodes of rejection and we treat rejection with multiple steroid courses, this increases the risk too. So here intensified anti-rejection therapy have the relative risk of 3.5. So the post-transplant diabetes increase 3.5 folds if the patient suffer from frequent episodes. This interesting carvedilol is associated to 2.9 increases, and as you see, these are the relative risk factor multivariate analysis of the study. From our experience in Mansoura, we found that hepatitis C positive is associated with increasing risk of post-transplant diabetes. Here, this is from the study that published by Muhammad Hamid et al. Effect of pre-transplant hepatitis C virus on development of new onset diabetes after transplant. Egyptian living donor renal transplant, allotransplant from Mansoura. This is the hepatitis C. And even more interestingly, that hepatitis C increases the risk of tacrolimus-induced diabetes. Gene polymorphism and the molecular studies shown that we have eight single nucleotide polymorphisms that are associated with development of diabetes. Another Asian Indian population showing that KCNQ1 and KCNJ11 are associated, gene polymorphism are associated with type 2 diabetes after transplantation. Very interesting. The serum magnesium at the time of transplantation. The lower the serum magnesium, the higher the percentage of post-transplant diabetes and affects the occurrence of post-transplant diabetes. So magnesium less than 2 milligram per deciliter at the time of transplantation is associated with less NODAT. This means that it is associated with more NODAT after transplant. So the lower the serum magnesium, the higher the percentage of patients who will suffer from post-transplant diabetes. If the patient suffers from impatient hyperglycemia, we should be careful in monitoring this patient because these patients may develop a post-transplant diabetes. Regarding the management, as I mentioned before, if we catch the hyperglycemia earlier, insulin is preferred. If it is late, we go through all the different treatment modalities like type 2 diabetes. There is some data showing that sitagliptin or vildagliptins are superior, and metformin is very good if GFR above 60. Hypoglycemic agents still requiring studies include GLP-1 analogs, sodium glucose transporter inhibitors, metformin at GFR less than 60. The mechanism of action of glucose lowering agent, this is either increasing sensitivity like glitazones, but we should be cautious because of salt and water retaining properties of this class. The sodium glucose transporter inhibitor, but we should be cautious about the new notion of FDA with the relation of acidosis with this class. Skeletal muscle improvement of glucose uptake, the pancreas, and on the liver. So a lot of drugs, and you can review these slides by stopping this video, looking at the different classes, the different drugs available, the main mechanism of action, and if there is risk of hypoglycemia or not. The same classes within GFR and their modification with different degrees of graft dysfunction. This one, although it was published within the oral hypoglycemia in CKD and not transplant, but it's very helpful because all the available oral antidiabetic drugs, and this is a pharmacokinetics and dose modification within the different degrees of GFR. So this is the green color refer to no modification, the yellow color refer to be cautious, and the red color means to be avoided. If we look at metformin, if the GFR above 60, no problem. If 60 to 30, 1.5 gram to 850. If it is in stage 4, 500 milligram as maximum and should be used cautiously. And this is all the drugs. Here you can find in the sodium glucose transporter that even in chronic kidney disease there is limited experience. Regarding basal insulin use, this randomized study included a small number of patients, but it showed a very nice and striking result. If we use isofen, which is intermediate basal insulin, earlier, you will find vanishing diabetes, and why the diabetes is cured or hyperglycemia vanished, because it was proved that basal insulin may be protective for the islets. Regarding our experience in Mansoura, the cumulative risk is 22.2%. Risk factors include age, post-family history, obesity, and steroid dose, and the outcome post-transplant diabetes is associated with more proteinuria, more graft dysfunction, more diabetic nephropathy, more hypertension, more ischemic heart disease, more stroke, more neuropathy, autonomic and peripheral, more retinopathy, and even all these are significantly association with post-transplant diabetes. And we have very interesting 11 cases documenting both the occurrence of diabetic nephropathy in the graft. This is the mesangium increasing, hyalinization, thickening of the basal membrane. So this is a classic presentation, although graft survival is not affected. This is funny to use metabolic surgery to bypass for the patient waiting for pancreas after kidney. To highlight or to summarize the post-transplant diabetes sector, post-transplant diabetes mellitus is an important complication that contributes to increased morbidity and mortality of transplant patients. Early recognition, this is very important to monitor the patient well. At risk is essential, so this is why I stressed upon the risk factors to try and minimize the development of post-transplant diabetes. Early insulin treatment of the post-transplant hyperglycemia to preserve beta cell may be effective strategy to minimize PTDM. When post-transplant diabetes is established, glucagon-like peptide 1 inhibitors and DP4 agonists may be the first line of treatment, and we are waiting the further studies for this conclusion. Regarding the third part of this presentation, which is kidney donation and dysglycemia, this is one of the striking news this month. Diabetic donor kidneys may carry increased risk of premature mortality and graft loss. Abstract that was presented in the ASN. Here the graft survival, this is cadaveric transplantation. Here we have two factors. We should look at if the donor is diabetic or not, and recipient age above or lower than 40 years. So the best survival attained if the donor kidney comes from non-diabetic person and the recipient is less than 40. But here, if the diabetic donor and the recipient is above 40, the lowest survival. For the graft, for the patient, this is the patient and this is the graft survival is the same. So we should look at the diabetic donor. The risk increases by 17%, and if the age above 40 of the recipient, it is increased by 99. So again, we should look at the 12 factors: donor state of the diabetic state of the donor, and the age of recipient, is it below or above 40. Regarding taking kidney from diabetic persons in the live donor kidney transplantation, there is a paucity of data, some naive data, but we don't agree upon it. This is the Japanese experience from single center experience that was published 5 years ago, showing this study included 444 donors for whom oral glucose tolerance was carried out, 75 grams, and normal glycemia was present in 373, no problem in this, but we don't agree in our practice with this sector to accept the donors diabetic 27 persons. These are not potential health, these are diabetic patients, and impaired glucose tolerance in 44. In our experience, in our work, we don't accept either neither diabetic nor impaired glucose tolerance are accepted for transplantation. And we agree with this algorithm. We assess the risk, body mass index, a history of gestational diabetes, a history of post of oral glucose tolerance, etc. And if it is absent, measuring fasting and hemoglobin A1C, fasting plasma blood glucose and A1C twice in all donor candidate. you may have fasting less than 100, persistent, and A1C is less than 5.17. This normal person proceed for transplantation for further evaluation. And if it is fasting blood glucose above 125 or A1C above 6.5, this is diabetic. No, not to be accepted. If oral glucose tolerance from 100 to 124 fasting and A1C between 5.7 and 6.4, perform oral glucose tolerance. If the blood glucose exceed 200, diabetic, not accept. If it's from 140 to 199, impaired glucose, likely not to accept. Sometimes accepted under certain circumstances after evaluation of cardiovascular risk and diabetic risk. If it's than 140, assess risk and maybe suitable donor, consider calculating diabetes mellitus risk, age and ethnicity. Although we agree with this rationale, but we don't accept at all to use kidneys from diabetic or impaired glucose tolerance. The European Best Practice Guideline recommended diabetes mellitus as a contraindication for donation to other than in exceptional circumstances. And they suggest impaired glucose tolerance is not an absolute contraindication for donation. In our experience, what about the development of diabetes or impaired glucose tolerance or impaired fasting after kidney donation? This is our experience. We found in our donor after kidney donation, and because we have a strict follow-up of all donors, and this is one of the unique criteria of our center, we found the impaired fasting and impaired glucose tolerance in 15% after donation. This is higher than general population. Diabetes mellitus 11%, especially for the risk factor for diabetes included age above 51 to 60, body mass index above 30, and a positive family history. So should be careful about the using of donor from this criteria. What's new? This is one of the notions from FDA to just to be careful when you use sodium glucose transport inhibitors. We don't use them at all in transplantation because the no experience and the data are limited. But in general, acidosis can occur. Regarding the islets and the kidney transplantation, simultaneous use of islets is associated with lower insulin dosage in comparison to patients who are treated with intensive insulin or waiting list on the pancreas loss. This is regarding the islets. The islets is not so successful because how to harvest islets from different donors, how to be injected, and one of the processing is to use heparin. Here there is a study showed that heparin is associated with amyloidosis, and using heparinase improving the islet. Another evaluation of islets by using enhanced ultrasonography using nano micropapillary contrast agents for islet transplantation. This is the ultrasound, and this is the contrast, and this is the mixed study. This is one of the practical statements that's very interesting and recent publication. A1C is very limited post-transplantation. Why? Because these are the data. This is the sensitivity. If you look at any cutoff point, you find different sensitivity and specificity. If you use low level of A1C, sensitivity increases, but specificity decreases. So you can look at every cutoff point and then look at sensitivity, specificity, positive predictive value, and negative predictive value. You will find this test is not good in transplantation, and still oral glucose tolerance is the gold standard for diagnosis. This is a very nice study because it shows that whenever we use a steroid in a low dose, this is not associated with high risk of diabetes if we use different criteria for diagnosis, except here the insulin use is higher if the patients are assigned or randomized to steroid avoidance. To end my presentation, I want to stress upon diabetes is very important. We shouldn't, although it's associated with many comorbidities, we should not deprive diabetic patients from kidney transplantation. If the patient has live donor, we can go straight for live donor kidney transplantation after thorough evaluation of the cardiac status and monitoring of the patients. Working in a team and multidisciplinary team is very crucial for the success, and I am honored to work in the Urology and Nephrology Center Mansoura, that the center that was founded by Professor Ghunaim, and currently we have transplanted 2,635 cases or more in our center. All of them are live, and the majority are live-related kidney transplantation. And this is my great professor, Professor Ghunaim. And I end with how to be successful. To be successful, we should concentrate on ideas, and we should avoid talking about people. We should forgive others, and avoiding holding a grudge. And the most important issue is to work together, because successful people, they want others to succeed. And thank you at the end. Thank you very much for your attention.